Join us August 21st for this month's Lunch and Learn with the Link, focusing on chronic GVHD of the skin. Our guests will be Dr. Rachel Rosenstein of the Hackensack Meridian School of Medicine and Ann Fitzpatrick, an MDS survivor. This free webinar will be Wednesday, August 21st at noon Eastern. To register, visit nbmtlink.org or follow the link in our show notes. This episode includes content related to reproductive organs and sexual health and may not be suitable for all listeners. Welcome to Season 14 of the Marrow Masters podcast, brought to you by the National Bone Marrow Transplant Link and sponsored by Insight and Syndax. The National Bone Marrow Transplant Link, established in 1992, strives to help patients, caregivers, and families cope with the psychosocial challenges of bone marrow and stem cell transplant, from diagnosis through survivorship. This season focuses on chronic graft versus host disease, or GVHD. We'll cover male and female sexuality, the emotional struggles of the disease, and even atypical presentations of GVHD from the perspectives of patients, caregivers, and medical professionals. Here's your host, Executive Director of the NBMT Link, Peggy Burkhardt.
Hello, everyone. So today we welcome with us Dr. Jose Flores, who works in sexual and reproductive medicine, urology at Memorial Sloan Kettering Cancer Center. Dr. Flores will cover male sexuality on this pod, a subject that can sometimes be difficult, but is so important. We're going to cover a lot of ground, and our hope is that you will feel more empowered to talk to your doctor candidly after listening today. Thank you so much, Dr. Flores, for being with us today.
It's my pleasure. Thank you so much for having me here.
So let's jump right in. Let's talk about the difference between sexual dysfunction versus erectile dysfunction.
Yeah, this is a key point when having the discussion with the patients, because sexual life is more than one erection for a man, okay? Sexual life can be sex drive, after surgery. There are so many other aspects in the sexual life that can be affected with any treatment. Not only the erections. It could be trouble with ejaculation. It could be issues with the orgasms. It could be issues with the sex drive. It could be issues with the penile shape. Sometimes we have some curvature in the penis, okay? It can affect or can impact the sexual life in those patients. So that's the reason when I said sexual dysfunction is more than erectile dysfunction. There are so many aspects that we can talk about it with the patients.
So let's talk about the prevalence of erectile dysfunction itself, ED, after treatment.
Well, it depends on the type of treatment, obviously, but it's very often, and we see in our practice, in men after cancer treatment, the prevalence of sexual dysfunction is really high. Almost half of them, they have some problem with the erections. Almost half of them or more, but obviously it depends on the type of treatment. For example, after any pelvic surgery, the prevalence of the erectile dysfunction could be much higher. After chemotherapy, it has been reported up to 60-70% of the men have some erectile dysfunction. What about low testosterone? It has been also super high in men after chemotherapy. After radiation, directly and indirectly gonna impact the sexual life too, especially if the radiation was located around the pelvis area.
Dr. Flores, let's talk about the initial assessment regarding erectile dysfunction.
Well, this is a good point because everything must start when I said we need to break the wall. Okay, we need to start talking about it. I know many men, they don't want to talk about it for many reasons. They're ashamed, they don't want to talk. The patient is not feeling confident to talk about sexual life. So this is also a point for the providers. We need to break the wall to talk about sexual dysfunction, to talk about erectile dysfunction. This is the first concept. And I tell the patients always, you can start telling your doctor, I have some problem. Can we talk about it? I have some problem with my partner, and this is the most important aspect in my life. Can we talk about it? So try to start the initial discussion, the initial conversation. And then we have many surveys or many questionnaires that we can ask the patients so they can complete it, and we have a score. And obviously, for example, the one is the most important is the International Index of Erectile Dysfunction. That questionnaire can give us a score and can tell us if the patient is having some erectile dysfunction and the degree of erectile dysfunction, mild, moderate, or severe. Okay. And then based on that, we can have other assessments, labs, physical exam. There is a lot that we need to evaluate when a man is complaining about erectile dysfunction or sexual dysfunction. But like I said before, the first step, we need to break the wall because this is important for your quality of life. This is important for your sexual, for your relationship. So the first step, we need to break this wall to talk about sexual life. Don't be ashamed about it. It's also a message for the providers, the doctors, the MPs, the nurse. Ask your patients, are you having any issues in your sexual life? With the simple questions, many patients can open and start talking about it. And we can see the patients start talking about, oh, I have this aspect and issues, how we can do. And the most important, there are treatments to improve the sexual life. There are many options that we can help the patients, and most of them is in an easy way. But obviously, first, we need to go with different assessment. But the first thing to do, we need to break the wall.
Dr. Flores, you know, the season is about graft versus host disease and the things that are really hard for people to talk about. We're covering female sexuality and, of course, male sexuality with you. Let's talk about what it's like for patients post-bone marrow transplant. They're dealing with graft versus host disease. How does their sexual function play into this topic of conversation?
Well, this is a huge point. There is so many research about that. Unfortunately, there is not so much data. The only thing that we can tell you, the prevalence of the sexual dysfunction, low testosterone and erectile dysfunction is very high. Around 70% of the men after a stem cell transplant or bone marrow transplant, they have low testosterone and erectile dysfunction, especially young population. So we don't know why. What is exactly how this is affecting? For what reason? This situation we can see in these patients after the treatment. So we don't know yet. The only thing that I can tell you that we know is the prevalence is very high. Okay. And that's the point when I said before breaking the wall, because likely the patients after stem cell transplants or bone marrow transplants, they're having some issues in the sexual life.
Yes. And do you see as time goes on, does it seem to get better for them as the graft versus host disease kind of burns off?
This is a good question. Based on the data that we have, around 2-3 years, the prevalence is almost the same. So without treatment, this is the most important, without treatment, likely the situation is going to be the same. It doesn't change. It doesn't improve. You need to look for help. Ask your doctor, ask your provider, health providers, what to do, because you're not going to have some resolution or it's going to start getting better just by itself. Unfortunately, no. You need to look for some assessment and treatments. That's the key point. That's the reason when I said, break the wall, start talking about it, because we have options. We have treatment that we can discuss to improve this big aspect in the quality of life.
Oh, you have such a way of talking about this. I would imagine your patients feel so comfortable with you, but we know that's not always the case. So thank you so much for sharing how you handle this and stressing the importance of taking action. So let's talk about what exactly is the ED model of care.
To treat erectile dysfunction, we always talking about the steps. Step 1, step 2, step 3, and step 4. Okay? The step 1, we are always talking about lifestyle modifications, sleeping better, exercising, eat better, not only for your sexual life, for your health status in general. And we're talking about using PDE5 inhibitors, classic sildenafil, tadalafil, the classic tablets that everyone knows in the market. This always start is our first start point. We have different kind of treatments. It could be taken daily one, it could be taken as needed. It could be a combination between daily and as needed. And I can tell you, 80% of the men are responding very well to the step 1.
Great.
And then when we're doing the assessment, the evaluation, and we ask the patient how you're doing with your sexual life based on the treatment. If they're responding well, we keep it with the step 1. If not, we start talking about the other steps. Step 2, we're talking about the injection therapy. Okay, the injection therapy is a medication that we train the patients how to do it, how to prepare the medication. This medication is injected. You need to inject the medication directly in the penis, okay? I know it sounds horrible. Nobody wants a needle in the penis, but for many men who want to have sexual activity and the pills, the tablets are not working, this injection therapy is an excellent option. Excellent. And again, when the step 2 is working well, most of the time, 90% of the men are responding to the step 2, we keep it. But then when it's not responding in our practice, we do other assessment to evaluate for what reason the pills and the injections are not working well. And then we're talking about the step 3 and step 4. The step 3 is talking about penile pumps. It's a device that helps, get the penis inside the device, pump it up, and that way you're getting blood in the penis, and that way you get erections. And the final step is just talking about penile implant, penile prosthesis. That's always our last step. We always tell the patients, go step by step. Don't jump from the tablet to the penile implant. Just go step by step because nothing can replace the natural erection.
Yes.
Versus one that is mechanical for the penile implant, penile prosthesis, okay? So always we insist the patients, just go step by step because likely you're going to be just between the step 1 and step 2, between tablets and injections. And talking to the patient, options to go step by step is going to be based on your response.
Okay. Wow. This is terrific information. Thank you so much. All right. Let's talk about Viagra and Cialis. Let's tackle the myths and reality of it.
Well, that's just a good point because I always tell the patients, these are no magic pills. Okay. This doesn't mean you take it, okay, and you get an erections. No. So number 1, for example, for sildenafil, Viagra, you need to take it with empty stomach. No food, no alcohol, because the food or alcohol is affecting the absorption of the medication, okay? So with Viagra, with sildenafil, if you want to maximize the action of the medication, you need to take it with empty stomach, okay? And then 1 hour after, you need sexual stimulation. It's not going to happen, you're going to get an erections and ready to have sexual activity. No, you need to engage, you need foreplay, you need to engage in the sexual activity so in that way you can get an erection, okay?
Okay.
That's with Viagra or sildenafil. With tadalafil, Cialis, the food or alcohol intake doesn't impact the absorption, but the absorption is a slow process. So you need time to get the maximum, the action of the medication for the erection. So you need at least 2 hours. Take the tadalafil, take the Cialis, and 2 hours after or more, get sexual activity, get engaged again. You need sexual stimulation for these medications to get in action, to get an erection. So like I tell the patients, there are a couple precautions that you need, especially with Viagra, sildenafil. If you want to have an erection, you need to take it with empty stomach. And both pills, you need sexual stimulation to get an erection. This is not a magic pill. This is important based on the UA guidelines. Around 60% or to 80% of the time when the patient is telling us, oh, the pills are not working, is because they're not taken properly.
That is so interesting.
Most of the doctors don't talk about it. So
yes.
That's in my area, obviously working. One of the first recommendations is how's the way to take it? Because the main reason when the pills are not working is because the patients are not talking properly. So that's the reason. And I think it's a huge important information how they can take it.
Okay. Are they a part of step 1 then?
Yes. It's always lifestyle modifications, and they use the oral medications, the PDE5 inhibitors, Viagra, sildenafil, Cialis, tadalafil. Like I said before, there's many different ways. It could be taken as needed, daily, the different dose, the daily dose, the full dose for when it's as needed, or a combination, daily dose plus as needed.
Okay, great. Are there any other ED treatments to discuss today?
Another option when the pills, the oral medications are not working well, injection therapy. Injection therapy is a good option. 90% of the men can get an erections with injections, but you need the training. It's important to have the training. It's important how, to do it because there are a couple of safety issues. The main complication when you're doing injection therapy is you're going to have a prolonged erections. That's an erection that is lasting more than 2 hours. That is also dangerous. Okay. So here in our practice at the MSK, we have a special training, a special program, and we tell the patients what to do in case they're having a prolonged erections. I can say in our practice, our prolonged erections is very low, but it can happen. So we prepare the patients what to do. This is how we make concern you're thinking about the injection therapy.
Okay, thank you so much. So let's move on and talk about low testosterone prevalence after cancer treatment and how you make that initial assessment.
Again, similar to what is going on with erectile dysfunction, low testosterone is highly prevalent after a stem cell transplant or bone marrow transplant. The reason? There is probably some interaction with the lady cells in the testicle level. In the testicles, we have those cells we call lady cells, the area where you're producing testosterone. So those, it happen that is not having a good production of testosterone, and you are ending with low testosterone. And it's again highly prevalent. Again, half of the men after bone marrow transplant or stem cell transplant, they're having low testosterone.
Okay. What about safety and treatment options regarding low testosterone?
Oh, wow. Really great questions, because there are so many aspects around safety, okay? Because first, testosterone is under control for the EA. So it's not just a regular prescription. It's under control. I think it's a type 3 substance that is under control. So when I said about safety, there are so many aspects that we evaluate before starting any testosterone treatment. And we have we call a testosterone checklist before, okay? The most important aspect is fertility, okay? If a man is still thinking about babies in the future, using exogenous testosterone, intramuscular testosterone or subcutaneous testosterone, oral testosterone can suppress the sperm production and ending with for a temporary azoospermia, meaning the man cannot get sperm in the semen. And obviously, without sperm in the semen, it's not possible to get a pregnancy. That situation, most of the time, is a temporary, but it can be permanent. So we always advise the patients, if you are still thinking about fertility in the future, it's important that you need to know this aspect, avoid any testosterone. And there are other alternatives, other options to increase the testosterone levels without affecting the sperm production. Okay, so this is other aspect that the patient needs to talk about that with the doctors, okay? Because if they are using testosterone, they can suppress the sperm production. That's number one of the issues. Another complication that is very common when you are doing testosterone treatment is that we call polycythemia. The hematocrit, the hemoglobin levels going up. And that is the point where going up too much, it can be associated with heart attack, stroke, deep venous thrombosis. So it's another aspect that we need to control. And the main reason that is happening, in many times the patient is having a sleep apnea. So one of the aspects we're trying to evaluate before starting any testosterone treatment is the patient have a sleep apnea. For men over 45, we need to evaluate prostate cancer. Because if you have a prostate cancer, you don't know that, you're starting testosterone treatment, that is also can get some complications with your prostate cancer. So one of the aspects we need to evaluate first is the patient doesn't have a prostate cancer in a man 45 years or more, okay? The another aspect always we evaluate is we call transference risk, okay? If the man is in contact with any kids or any children under 12 years old and using testosterone in gel, even though the patient is washing the hands very well, they can keep testosterone in the hands and can transfer to the kids. It's a FDA warning about that, okay? So in our practice, we don't prescribe testosterone in gel if the man is having contact very often and close with any kid that is under 12 years old. So as you can see, there are so many aspects in safety. There's so many aspects you need to evaluate before starting any testosterone treatment. So it's very important for the patients, go to the right provider who knows more about testosterone, because it's a treatment. They can, obviously, it's going to help you in your quality of life. You're going to have more energy. You're going to have a better sex drive, but it must be safe. So it's very important for the patients to go to the right providers.
Okay. I have a question for you about a younger patient, so a young adult. Do you find that it's hard for them to talk to you about this when their fertility is a consideration? Is it really difficult for these young men?
Yes, it's difficult. That's when I started always, we need to start breaking the wall. I don't know, probably because I've been working for this area so many years, for me it's easy to talk about it. But I understand for my patients it's not easy. So now we start starting, with the first questions. Are you still looking for more babies in your life?
Yeah, or any babies if they're young and they haven't had any yet.
Yeah. And then they say yes, no. And based on that, I started having the discussion. Okay. For the patients, it's not easy to talk about fertility. Okay.
Yes.
It's critical because patients after stem cell transplant or bone marrow transplant, usually they are young population. Okay. And there are so many concerns about fertility. And there are so many aspects to start talking about it. Okay. So always attend the patients. if you have some concern about fertility and you had those treatments before, the first things that you have to do is check your semen analysis. You have to do a semen analysis because it's the first step. Don't wait and say, oh, I have 1 or 2 years trying to conceive, to get a pregnancy, and it's not happening. Probably because there is some issues over there. And again, there are treatments that we can help you to improve your fertility, to get the chance to get a pregnancy. But we need to start with the first step, semen analysis, hormone labs, hormone profile. But again, we need to break the wall. We need to ask the patients. And one of the simple questions, are you still looking for more babies in your life, or you want a baby in your life? Many times they're coming with a partner. They have not been talking about it, but the partner wants one. And they say, oh, hey, what is going on? What is the status on this? So the easy answer for that is, well, yes, we can start talking about it, and we have options. That's the most important.
Yes. Well, and that leads me to think about preservation. And, here they are about to fight for their life, and they have to be thinking about preserving. Is that correct? Preserving their sperm and getting that.
That's correct. That's the key point. The best things to do always first, try to preserve your fertility before any treatment. The guidelines are clear. When you're having all these treatments, you're thinking about fertility in the future, try to do some fertility preservation. Bank sperm is easy. You go, we have here in my location in New York, we have so many options to go a place, bank sperm over there. Always tell the patient, that is going to be your saving account for your future. A saving account, because you never know what is going to happen. There is a possibility, obviously, the sperm is going to get recovered and it's going to be no problem with your semen. But there is a huge possibility, unfortunately, after treatments, especially bone marrow transplant, around 30-40% of the men, they have some abnormal semen analysis. There's a possibility that you're going to have some issues with the fertility. So obviously, first, go bank sperm. It's going to be a good saving account for the future. And then if the patient didn't bank sperm, for example, okay, we start talking about what to do. What is going to be the options, the treatment, medications, surgical procedures. There are some medications we can start and give it the chances around 50%, the chances to improve the semen analysis. If not, that is not working. And then we're talking about surgical procedures. So one of them is called testicular sperm extraction. We try to go into the testicle, open the testicle, and under microscope, we're looking for the best tissue, because when we identify the best tissue, we send it to the sperm bank. The processing, we have around 60% chances to find a sperm over there. And then those sperm can be used for any fertility procedures, especially in vitro fertilization. Okay, so the final outcomes to get a pregnancy, to get a baby. So as you can see, we have options to talk with the patients. But again, everything we need to start. And as a doctor, always I'm asking the patients, but I'm telling them, so for our audience, one way to start talking is asking the providers and see what to do, what options they can have to improve those aspects.
Oh, this is terrific. Thank you so much. I think we've covered just about everything. Is there anything else that you would like to talk about before we wrap things up?
Well, always I'm telling the patients, be proactive, okay? Be aware about your health status, okay? Don't wait until somebody's going to ask you about your sexual life. Somebody's going to ask you about your fertility. Be proactive. You be first. Break the wall. Start asking, tell your doctor, say, doctor, you know what, that is happening to me. There is any help? Or ask for referral. We have doctors who have been training in a sexual and reproductive medicine in the U.S. So there is always someone to go and ask for help, ask for options. But I think the main concept today is be proactive and ask for help.
Has anyone ever sent you a picture of their baby?
Actually, yes, a couple of times. And that's made me my day, because it's telling me, oh, wow, I'm doing a good job. And at the same time, I'm feeling so frustrated when I have to tell the patients, I'm sorry, we didn't find any sperm. So I have both sides, okay?
Yes.
It's always, expectation is very important for the patients. I'm telling the patient, I'm here to offer you options. You're making the decision, okay? But and also at the same time, you need to have real expectations. Because I know for fertility, when we don't find a sperm with the surgical procedure, that is always our last option, it's a really bad news, okay? But at the same time, we find a sperm, It's a good news. And a couple of times I got some of the pictures, and those is the happy endings, but sometimes it's not. But again, real expectations. But again, I think the most important for the patients, be proactive.
Well, this sounds terrific. Thank you so much. You said it several times. Be proactive. Break the wall. Do you want to talk about that a bit?
So, for example, yesterday I have a couple, telemed couple, after bone marrow transplant, both in front of me. And they're telling me, thanks, doctor, we're getting back to the sexual life after 1 year with, affecting with the after treatment with ED. And I told them, they made my day because that's exactly what I'm doing. And like I say, doctors, thank you so much. We are now back to having a, good relationship. And you see the changes, men and women. Wow. So fixing different aspects, testosterone, ED, sexual life. We have a psychotherapy too. I didn't talk about so much about it, but our therapist, Dr. Chris Nelson, helps us with all the mental part. I always tell the patients, 50% is physical, 50% is mental. My role is to fix the physical part, but there's so many aspects in the mental part that I cannot fix. And my partner, my work partner, Dr. Chris Nelson, who's working with, therapies, working with the mental part. And so many times I see so many changes because they're fixing the anxiety, depression, many things around when they're having some issues about erectile dysfunction or fertility. So at the end, I always attend the patients with the one appointment or talking about it. Most of the time it's not enough. We need 3 or 4 times to talk about it, try a couple of treatments, test them, see how this is working or not. See how they're doing with the therapies with Dr. Nelson. So, wow. At the end of the road, I always am telling you, I see more success than fail. That's the reason I say, wow, I'm doing the right job and I like it.
Should we call you Dr. Romance?
I don't know. I didn't think about it. But I think it's we're always taking the patient because sexual life, again, is more than erections. There are so many aspects. Many times I'm spending, 40 minutes talking about different aspects, mental and relationship. It's not only one, it's 2 in the sexual life, physical part, mental part. So that's the point. There's so many aspects that we need to cover.
Thank you so much.
Nobody is going to go if you don't go first. Nobody's going to be worried about your sexual issues or your fertility issues if nothing is starting first from you. Because everything is going to be much easier and you're going to find the best option and solutions to improve your quality of life if you're starting the process. Talk to your doctor. Ask them, hey, any options for this issue that I'm having and affecting my relationship with my partner, or I want to have a baby in the future. I don't know what to do. Let us break the wall. Let us start, be proactive because there are so many options around. There are doctors with the training to help you with that. So I think that should be the first step and the main message coming from this podcast.
Well, thank you. Thank you so much for handling a very delicate subject in such an incredible way.
It was my pleasure. Thank you so much.
This has been the Marrow Masters podcast. If you know someone who would benefit from the information in our show, please share this episode with them. And don't miss future episodes of our show. Follow Marrow Masters for free on Apple Podcasts, Spotify, YouTube, or wherever you're listening right now. And to connect with the National Bone Marrow Transplant Link, visit nbmtlink.org or tap the link in our show notes.